the main aspects of my role in the development of the project for New Ways of Working has been to develop a model of stepped care with all of the principal stakeholders and to develop new ways of working in terms of the graduate mental health worker role. So that was helping get it established, get it agreed, get it funded, and then to actually get the people recruited, to get them trained, and then to look all of this while about what's the best way to use that resource.
Well, I think the difference it's made for me in the role of graduate worker is the fact that it's provided a new opportunity, really, a new learning experience. Coming out of university, opportunities for graduates are very slim, really. I started off life as a support worker and then moved on to an assistant psychologist position. And prior to this position of graduate worker, there wasn't really any other avenues for me to explore. The graduate worker role itself enables me to gain additional clinical experience and to work in new ways, presenting community classes and seeing clients one-to-one.
There have been a number of challenges in implementing the graduate worker role. For a start, it was quite a cultural shift for people. So people were used to the conventional professional roles of, clinical psychologist, CPN, counsellor, community mental health team. This was a new role, and I think people were initially quite sceptical about what would this new staff group have to offer. And I think in some ways people felt a little bit threatened that maybe this was undermining the value of some of those other professions, which it certainly is not meant to do, of course. It's about saying, can we get the skill mix better than it is now? Can we make better use of people at different levels to improve our capacity and therefore our accessibility to service users?
New ways of working for me and in my job is that as a psychologist, but also as a team leader and as a clinical lead, what I can do is make sure that psychology is really influencing all the decisions, all the clinical decisions and all the thinking that happens in our team. So it's sort of a consultant role, but it's actually more about just embedding the thinking in the services.
The new ways of working, and particularly the graduate worker role, for me personally, this has meant that what we can do is really plan to make services much more accessible and to hopefully, what we're hoping it will do is to reduce the impact in terms of waiting times. We do have difficulties in psychological therapies in terms of waiting times. What we're hoping is that if people can access something that's evidence-based but much sooner along their personal pathway, some of those people won't need further more complex interventions later. So that will help us in terms of feeling that we're able to deliver our service in a more timely fashion. I would have to say that that's not happened yet. It's too early days for that, but I'm looking forward to the day when that has a real impact, subtle impact on our practice and obviously very much on the service users themselves.
I think the role of graduate worker in particular has been very helpful for the team in which I work. Previously, the gateway workers are having to see very complex cases as well as very simple presentations. At the lower end of intensity treatments, a lot of their time was consumed with cases that could have been seen elsewhere with people with less expertise and speciality.
What we were trying to do was to make sure that we matched the service users' need to the level of service that they would most benefit from straight away. Stepped care is a bit different from that. What stepped care says is that you should try and offer a low intensity intervention first, as long as there's not a real contraindication to that, such as risk, and then see what the person needs, so we don't assume that they need a very complex and intensive intervention unless that proves to be the case.
We had another young man that we worked with who wouldn't accept any help. And what happened was that he just wouldn't even see us, never mind take medication. And instead of thinking, well, the only way we can help this guy is by getting him on medication, we'll have to use the Mental Health Act. What we did was we worked with the family and we supervised the mum to do a psychological formulation intervention with the client. And what he did was, the mum was great, she just used to leave it lying around. And eventually what happened is he disclosed what trauma had happened that had troubled him. And once he described that, his relationship with his mum warmed, he started to work again with his dad, he started to go out drinking a bit more often, he started to sort of socialise. And although he's never been on medication, he's only seen a mental health professional a couple of times before he absolutely refused, he's still working, as far as we know, and has got a girlfriend, and he's been discharged about 18 months now from our service. So I guess you've got a psychological thinking there about how you understand what might be going on and what you might be able to do that led to a very different kind of treatment plan, rather than the more traditional and perhaps a safer option of just bringing him into hospital and forcing him to take medication.
I think some people, it's a great opportunity to be seen quickly within psychological services, to be seen within a week or a couple of weeks, where previously they may have had to wait 4 or 5 weeks. so it increases the access to psychological therapy. For other people, they've come along to stress control classes, and that's been an education for them. All they needed was a little push along the way.
I think that a service user who'd access these stress control psychoeducational classes would be likely to emphasise how helpful it's been to have something that really helped them understand their problems and make really practical changes in their lives that would improve their health and well-being, and that it was easy to access and it was non-stigmatised. It was like you're just going along to the leisure centre. It was like going to an adult education class. So I think those are some of the ways in which a service user might say this is a particularly helpful way forward.
One client who came along to stress control class was very fearful of doing anything new, setting foot outside her home, going away on holiday. She reported that by the end of the class she felt empowered and a new sense of being able to do things once more. She was able to go away on holiday and to travel by herself and to take flights, which is something that she'd never dreamed of prior to doing the class.
I guess what's different about how we operate now and how we run our service is that we go to people much more. Although we have a clinic base, we don't actually see many people in that clinic. Most people don't want to come. So a lot of the work we do, probably most of it, is in people's houses, but we will also take people off to coffee shops, take them to play pool, almost anything to engage people. So an example would be I worked with one man who wouldn't have anything to do with mental health services, didn't believe them for him, and the only way I could really engage him was actually by getting and going to play pool with him. So I used to take him to the pub, play pool. He used to thrash me. He felt better. I felt bad, but he kept engaged, and I kept wondering, is this making a difference or not? And then he refused to take the medication which I'd managed to persuade him to take. And I went out and the family called me out and said, well, he's not taking his medication, he's deteriorating, he's drinking heavily. And I think because I had enough of a personal relationship, he listened to me and went back onto medication. So all that time in the pub seemed maybe a bit of a waste of an expensive professional, but it probably cost equivalent of 2 days in hospital. Never mind what it would have meant for him being in hospital, the stigma of that, what he would have felt and his family would have felt if there'd have been no other choice than to bring him into hospital and force him to take medication under a section.
It would be really helpful to be able to measure something like a cost-benefit analysis of what we've got out of new ways of working. I think that's really hard to do, but some of the things that we could measure could be accessibility to service users. It could be how many people are we managing to see. It could be looking at the pathway, what happens with some of those people. Are they actually then able to stay in primary care and not need to come through to secondary care mental health services? I think there's another kind of cost-benefit analysis, which is in terms of the organisation and how much time and resources are invested in the new workers.
I guess one of the things that is really helpful for EIP services is that they often, as a new service, it recruited a lot of really good staff, but even then there's sometimes worries about trying to practice differently. And I think the key for me to help them do that is to actually make them feel safe in what they're doing. And that's one of my reasons why I love team working, is that I think you can really spread the risk. And I think one of my key jobs is to help people feel confident to take positive risk management decisions, and rather than go into kind of cautious practice. And I think if people feel safe and contained, they're much more able to make those decisions, to think outside the box.
Well, I think the graduate worker role has made quite a significant difference to the team that I work with in Cramlington. I think as my role has developed, they've got used to my position being available. They're quite keen, really, the gateway workers, to refer on new clients, a lower level of intervention, and they use that facility quite often. So I think it's very much been about building relationships within the team and becoming part of the team.
I think we all now accept that we need a biopsychosocial approach to really help people, certainly with psychosis. And so we need to empower the psychological and the sociological messages in that, and then work as a team where those voices are all heard and we make decisions together about what's the best way forward. And I think that's got advantages for everybody, for nurses thinking more psychologically, for psychologists where the voice is heard, for psychiatrists who feel that some of the pressure on them is shared with other team members, and that lots of voices influence how decisions are made.
What I'd like to see is new investment in this area, and I'm hopeful that might come through the IAPT programme, the Improving Access to Psychological Therapies programme. We know that the government has announced there will be new monies there, so I'm really hopeful that will enable us to roll this out further.